patient that you need to be aware of. Pediatric age group, as much as it's very fun to deal with, it's a very vulnerable age group, and you have to have specific consideration once dealing with them. As a pediatricians and doctors in general, you should be advocated for caring of kids, okay? Try to take your patient as a whole, okay? So if you have a patient that you need to evaluate, see, take history from, do physical examination for, try to take them as a whole. So don't focus on the main problem or the main chief complaint, because you can discover or unleash so many interesting facts and secrets and findings if you take a patient as a whole. This is the aim of our rotation, is to teach you how to take the patient as a whole and deal with them as a whole, okay? And this is what makes a difference between a good doctor and an average doctor. Some challenges that you might face examining pediatric age group is the cooperation of kids. This is not always guaranteed. So many factors play a role to whether the kid is cooperating or not, like the overall well-being of the kid. If the kid is in pain, there's no way they're going to cooperate with you. If the kid is very irritable for any reason, very young, it's sometimes really difficult and challenging to get them to cooperate. So you'll have to use your magic and tips to get them to cooperate with you. And sometimes this can be, as I said, very frustrating and challenging. You have to also consider that the developmental status of the kid can affect or influence the expression of the disease that you're... I tried, but still it's not working. Not water, I think. Can you hear me? As I was saying, the child's developmental status can influence the expression of the disease, its finding, and signs that you'll be able to pick up during physical examination. You also need, because you finished your medicine rotation, signs and symptoms or signs of diseases that you pick up in adult age group sometimes are different from those you pick from pediatric age groups. One important note that you need to keep in your mind, the core of physical examination, as you all know, starts with taking proper vital signs. So vital signs in adults are constant. There's constant values and numbers that you need to look at and compare the normal between and the abnormal. However, with in the pediatric age groups, each group and sometimes gender has its own specific normal ranges that you have to refer to. Not all of them need to be memorized, but you have to be aware of the differences. Sometimes you can look up the differences or the normal ranges, so keep them with you, like charts on your tablets, iPads, etc. But you have to consider the differences according to age and gender. One important note also, that when you're dealing with kids of chronic illnesses, like someone with chronic kidney disease, chronic liver disease, you have to appreciate how chronic illnesses can impact on their growth parameters. We know that each child is born with what we call genetically determined growth potential that they need to reach if they have the perfect or proper environment and good overall well-being. However, unfortunately, kids who are going through chronic illnesses, they may not reach their genetically determined growth potentials, and they may present to you with failure to thrive, like those with UTI. So even simple UTI, if it's recurrent and chronic, can cause growth stunts, chronic kidney disease, chronic liver disease, chronic cardiac illnesses as well. So also, I need you, when you take history and do proper physical examination, when you put growth parameters on the growth charts, to appreciate how their chronic illnesses can impact on their growth parameters. So age groups in pediatrics are divided into many groups that can interact. So the neonatal period is considered the first month of life. infancy, the first year, and childhood as a whole from the age of 1 to 15. And it's further divided into toddler period around the age of 2 years, preschool from 2 to 5, school age from 5 to 15, and then it integrates with the adolescence group between 13 and 19, which is sometimes very challenging and difficult to deal with, like adolescence and teenage, we call them troublemakers. Before you start physical examination, always wear a smile on your face, regardless of how stressful, exhausted, frustrated you feel. Try as much as possible to be kind. This will help you allay anxiety and promote confidence between you, the patient, and their parents. And you will notice that sometimes, just if you don't look very kindly or friendly, parents will not let you examine their kids. Sometimes they may not be very cooperative even when you take history from them. So try as much as possible to be very kindly and friendly when interacting with patients and their parents. Okay, another more points to remember. Dealing with children and pediatric age group in specific is an art, and it needs practice. It depends on your skill that you sculpture during your pediatric rotation. So we teach you the basics of physical examination, but you will notice that performing the same physical exam on the same kid, you will have different skills. Some of you will exceed and perform proper physical exam, but some of you may not be able to. So this depends on how skillful you are and how patient and persistent you are in practicing and doing physical examination. Remember, the more you practice, the better you get and more skillful you become. It's not like you need to take history and physical exam once a week and then you keep repeating for each and every doctor you encounter during the week. So it's not like you need to just to get the boxes ticked, okay? It's for you to practice and to build your skills, which will help you in your OSCE exams and later on during your career as doctors. Be patient when dealing with kids. You need to be patient. This is mandatory. Be aware of variation according to age, as I was just saying, how vital signs are different, heart size, liver size, etc. Try to keep any disturbing procedures till the end. You don't want to disturb the kid at the beginning, because if so, if the kid becomes disturbed or irritated, you won't be able to proceed or complete a full physical examination. We taught you in the introductory course a sequence of physical examination. You start with inspection, palpation, percussion, auscultation, etc. You don't need to follow this sequence when doing physical exam on kids, okay? You need to complete them, all of them, try to, but keep, for example, if you have the privilege to evaluate a kid with bronchiolitis or asthma, we've got wheezy chest. So it's really not a nice opportunity to use, like to listen how a wheezy chest sounds like. So try to do auscultation at the beginning before the kid gets irritated or disturbed, and then leave the rest of these sequences till the end if you could perform them all. But start with what you think is the most important step of your physical exam that will add to your assessment. Okay, so why do we perform physical examination? What's the reason? What's the aim?
Find signs that indicate the underlying disease.
Exactly. So we need to complete, what we reached. Yeah. So when we take history, according to the histories, as we learned in the introductory course, we analyze the chief complaint, we analyze the associated symptoms, the associated or the specific system, and then other symptoms of other system. We analyze risk factors, and this, by the end of our history of presenting illness, we'll be able to find like a list of common differential diagnosis, right? So these differential diagnoses, you need to either prove them wrong or right, and physical exam really help you. So if you examine someone with respiratory distress and you think of bronchiolitis or asthma exacerbation, the kid is not wheezy, and this is the first presentation. The kid did not receive any treatment, but he's not wheezing. it's unlikely that the kid has bronchiolitis or asthma. So we'll put these differentials at the bottom of your differential list. So we kind of complete the primary impression that we reach through history by physical examination. We know that performing proper history and physical exam, you will reach 80% of the right or correct differential diagnosis. So proper physical exam is really, really important. Another aim or target to why we perform physical examination is to actually classify patients. Are they very ill just by looking at them? Ill looking, well looking, how they're doing, their overall well-being. This is a very important first step of your physical exam, to recognize critically ill children. Okay, later in your life you might be the ER doctors. People will be depending on you to triage these patients, to tell the doctor on call on the ward whether you have a patient that needs ICU admission or ward admission or can be discharged home. So part of your physical exam to recognize critically ill children, to be able to act upon that later on. Again, part of your analysis or examination to tell whether the kid is conscious, alert, oriented, of course depending on the age. The breathing pattern, are they breathing normally, comfortably, or they have labored breathing and they need help. To also recognize how they react to the environment. Are they talking? Can they complete sentences? Are they interacting with their mom surroundings? Are they playful? We know that kids, specifically in toddler age, they're like running cannons. They don't rest. This is their nature, to keep running, to keep exploring things. So if I see a 2-year-old kid in the emergency department or on the wards who's staying still, laying still, not moving, this is alarming. Okay, so the overall well-being is very important that you need to judge it by just looking to the patient. Even their cry can give you hints. So if you hear a baby crying with very low pitch, or what we call it weak cry, this is also one of the alarming signs. Weak cry, normal cry, high pitch cry, you need to comment on those findings if you face them. How their speech pattern, okay? Are they dysmorphic? Do they have dysmorphic features or not? Do they look pale, cyanotic, jaundiced, etc., plethoric, or very congested and red? You need to comment on all of these findings, and we will talk about these in details when we do skin examination. Try as much as possible to do physical exam while the kid is properly exposed. However, exposure doesn't need to be complete, or you don't need to do exposure all at once, sometimes gradually. So if you need to do full physical exam, start, for example, with a chest exam, expose the chest, finish, cover the chest, then go to the abdomen, expose the abdomen, etc., lower limbs, and so on. Okay, so starting physical exam starts always with vital signs. You need to judge whether the patient has normal vital signs or not from the name. The name implies that they are vital, so they are a very important part of your physical exam. So temperature, and we know the normal values of temperature. So rectally, any temperature above 38 is considered fever spike. This is the same for tympanic, because we call them core body temperature. So they reflect our core body temperature, the tympanic and the rectal temperatures. It's not the case for the axillary and oral route or path or way. So through the oral route, so anything above 37.5, and axillary anything above 37.3 is considered fever. You have to check respiratory rate, heart rate, blood pressure, and the fifth vital sign that you don't need to dismiss is the O2 saturation. Again, growth parameters are very, very, very important. So last pediatric run, one of the OSCE stations where simply we asked them to measure growth parameters of a doll. How easy is that? A doll that is staying still, not moving, and to plot them on growth charts, and you'd be surprised of how many students failed first to measure growth parameters properly, okay, and how of them also failed to recognize which growth chart to use and how to use them. This was really frustrating. as I say, the differences between adult and pediatric is just a few specifications. One of them, growth parameters, okay, and plot them on growth charts. How hard is that? It's not hard at all. So not mastering measuring growth parameters and plotting them on growth chart for me is very frustrating, and it's a shame that you finish your pediatric rotation not able to do so. Okay, so with each physical exam you pursue, either you measure the growth parameters yourself, which is again a skill that you need to practice on doing, okay? Or simply, if you don't have the time or the luxury to do so, go back to the patient's records, get their growth or the already measured parameters and plot them on the growth charts. It's not a hard thing to do, it's not a hard task to do. Okay, as I was saying, normal ranges do vary according to age. For example, this chart, you can print it out, carry it around with you, and with time, with practice, you'll be memorizing it more quickly. For example, having a heart rate of 160 of a newborn baby, someone who's just born, I wouldn't be petrified or worried, okay? But if I see a 5-year-old kid presenting to me with a heart rate of 160, I'd be really concerned and worried. So I need to evaluate him further. I need to double check, is this reading normal or is it related to him being distressed, in pain, crying, etc. So always be aware of the age-based differences of vital signs. So this is how growth parameters look like. So the CDC and the World Health Organization came up with some like age and gender specific growth charts that we plot growth parameters on, and they are different because, so why do we have different growth charts according to age and gender? Because growth pattern and growth rates both do differ according to age and gender, okay? So for example, just quickly to view that with you. So this one, the first one on this one. So this is, as you can see, the color is blue. So simply this is for a boy, and some of those we examined in the OSCE, they failed to recognize which one is for boys and which one is for girls. And if you could not recognize the color, up here, 2 to 20 years, boys, simple. And here, birth to 36 months, again, boys, okay? This one is for weight and stature, or height, length, whatever you want to call it, okay? So for example, if I have a kid who's 5 years old and he's only 10 kilograms, so I need to know whether they are catching according to their age or not. So this is the age of 5, a line, vertical line reaching above to meeting 10 kilograms, which is here. Can you see? So what I need to tell, what I need to say, that this kid is way below the 5th centile. So this curve is divided into centile. Each curve, as you can see it, is a centile. 5th, 10, 15, etc. up to 90 or 95, okay? Anything between the 5th and the 90th or 95th centile is normal. Anything above the 95th centile is abnormal. Anything below the 5th centile is abnormal. Abnormality means 2 standard deviations from mean, okay? So this is simply what you need to do when you plot the growth parameters. The parameter that you need with the age and where does it lie on the growth chart, which centile, okay? واضحة الأمور? Okay, so these are the curves. So this growth chart is for a boy, for boys between 2 and 20 years, okay? And this chart is for, this curve is for weight, and this curve is for stature or height, okay? So you checked the weight of your patient, and it was, for example, 10 kilograms, and he's 5 years old, okay? So this axis is for age, as you can see, age in years. 1, 2, 3, 4, 5, 6, etc. And this axis is for the parameter that you need to check. Here is the weight, for example, okay? So someone who's 5 years old, I should start from here, 5, okay? And I should draw a line, imaginary line, or using your pencils, pens, whatever, meeting 10 kilograms. So, parallel to 10 kilograms, height 10, parallel to it, height 5. They meet on this point, صح? So where does this point lie with comparison to the centiles above? Is it? Sorry?
حسب الريفرنس له انه abnormal بيكون.
طيب, where does it lie? What should I say?
below
Below what? The fifth. لأن أوطى إشي, the lowest thing is the fifth. I need to compare with أقرب إشي عليه fifth. So it's below the fifth centile. So anything below the fifth centile is abnormal. Okay? So this is how girls' growth charts look like. Same but pink. 2 to 20 years, birth to 36 months for both weight and stature or height. And a separate growth chart for head circumference. Again, there should be one for boys and one for girls. Okay. So we use the same thing. Birth. So according to age, and then the measurement that you measured, you plot them and you check which centile they lie on, between the 5th and the 95th centile. Okay. So you start your physical examination usually observing the largest organ and the most, visualized one, which is the skin. And examining the skin gives you a lot of hints about any underlying pathologies if present. You'd expect you to comment on the skin color, which is very obvious. Is the patient is the color normal? Is he pale, cyanosed, jaundiced, etc.? Any discoloration, discolored patches. By that I mean any hyper or hypopigmented lesions. If yes, you need to comment how many and their location, which sides, and the size of them. You have to estimate the size of these hypopigmented lesions. Any exanthems or rash, and you should be able to describe them. Are they petechial rash, pinpointed, purpuric rash, papules raised, pustules raised with secrete, like with pus-filled vesicular, like what we see in chickenpox. You need to describe the rash, the distribution of the rash, and the nature of the rash. Any edema or subcutaneous fluid accumulation. Skin turgor as part of your skin examination, which is helpful in assessing the degree of dehydration. For example, you are assessing someone with dehydration or gastroenteritis. So with skin, I need to look at their skin. For example, if someone has chronic diarrhea or gastroenteritis, is their skin dry, scaly or not? Because this reflects the degree of dehydration. Is the skin turgor normal or delayed skin turgor, okay, or abnormal? And for someone who's got hypernatremic dehydration, you will learn about this later on, they will have what we call doughy skin, like dough, say العجينة. So touching your abdomen, for example, you will feel like it will feel like you're touching dough, or so we call it doughy skin. This is a sign of hypernatremic dehydration. So skin examination can tell you a lot about any underlying pathologies. And then you need to comment on the head and the head shape. One important characteristic of the skull or head of pediatric is that early on, specifically in the first year of life, where their brain is expected to have accelerated growth, to make this growth, their skull bones need to be need to be soft to allow the brain to grow. A brain will not be able to grow if it's very restricted with something really rigid, right? It will be like a cage. However, the skull bones early on, specifically in the first year of life, it's really soft to allow the brain to grow. However, this softness might cause what we call cranial remodeling, meaning changing in shape of the skull according mainly to posture, okay, the posture of the baby. نسمع كثير أو شفت كثير بيبيات لما ينولدوا, if they're always lying on their backs, they might be flattening of their occipital area or on the side, etc. So the head shape can undergo what we call remodeling according to the posture. There are other pathologies that can affect the head shape. We're not going to talk about them today, like craniosynostosis and others. So let's review the abnormal shapes that I need to comment on examining. The kids start with plagiocephaly, as you can see. So this one is the most common skull or skull shape malformation that you will face. It means unilateral occipital flattening. As you can see, this is the occipit. On the unilateral part of it, one side is flattened. Okay, we call it plagiocephaly. Deformational brachycephaly or brachycephaly, this one. Okay, as you can see, it's central occipital flattening. Okay, so from the center, as you can see, this is a normal occipit, how it should look like. Okay, see how it's flattened from the center. So this is brachycephaly or deformational brachycephaly. The other one is the brachycephaly with asymmetry, as you can see. Okay, so it has both characteristic of brachycephaly and plagiocephaly. Okay, central and unilateral from one side. We call it asymmetrical. And the scaphocephaly or scaphocephaly, as others call it, there is very elongated, or the longitudinal axis of the skull is much more than the width of the skull. So it's the elongation of the skull. So we'll have a very long axis of the skull. Okay, so these are the main abnormal shapes of skull. You have to also comment on the suture lines that connects the skull bones together. You have to comment on any bony defects, any lesions, any scratch marks, any swellings, their location, size, consistency, etc. You have also to touch gently the fontanelles if we are dealing with someone with open anterior and posterior fontanelles, and we have to comment if they are the size of them and are they tense or not. For example, if you are evaluating a kid with meningitis or any pathology that causes increased intracranial pressure, you will feel the anterior fontanelle very tense. It should be soft. Okay, if you are examining someone with gastroenteritis and severe dehydration, if you touch the anterior fontanelle, it would be depressed as a sign of severe dehydration. So again, skull examination can tell you a lot about the underlying pathology. Don't forget to comment on the hair and the scalp if there's any abnormality with the hair. Okay. Okay. Eye examination. So ideally, eye examination should include examining the visual field, and this is something more sophisticated than what we do usually in pediatric examination. So examining the visual fields, evaluate for strabismus using the light reflex uncover eye test, look for any obvious nystagmus. You have to comment on the conjunctiva to look for signs of anemia, sclera for jaundice, the cornea for any opacification or haziness. You have to comment on the pupil size, shape, and reactivity to light. Both pupils should be equal in size, shape, and should react to light equally. And of course, fundoscopic examination if you suspect increased intracranial pressure to look for signs of papilledema. This is usually done by ophthalmology doctors, not by us. Ears exam, okay. Looking at the ears, the position of the ears. Are they low sit ears? For example, what does low sit ears mean? So if you draw a line from the corner of the eye straight, this is where the upper part of the pinna should lie. Okay. However, if it's lower than this, as you can see in this photo, so I will draw a line, horizontal line. Can you see the ear? It's low set. It's lower below, much lower than the line I just drew. Can you see? So we call them low sit ears. So comment on the ears, the position of them. Low sit ears are in normal position. The size, are they elongated, large? This can be a dysmorphic features of some syndromes like Angelman syndrome. Are they small? Again, this could be another sign of dysmorphism. And you also have to comment on the cartilaginous part of the ear. Some kids are born with congenital anomalies. They don't have enough cartilage in their ears, so the ears will be dangling down because they're not supported by cartilage. You also have to examine the tympanic membrane to look for any congestion, any bulging, any signs of infection or perforation. Of course, hearing evaluation should be part of the physical exam, but we don't do that usually. One important part that you need to examine specifically if you're looking for a hidden infection. So sometimes you'll be facing kids admitted to rule out some sort of infection because they're presenting with high-grade fever and physicians could not find focus for the infection. One of the common hidden infections in pediatric age group is otitis media, and as a complication, mastoiditis, which is spreading of the infection to the mastoid bone behind the ear. This infection is very serious and it carries a high rate of morbidity and, if not treated, sometimes mortality. So it needs to be managed and treated promptly with broad spectrum antibiotics. Sometimes it needs urgent surgical debridement. Okay, so all you need to do to just palpate behind the ear, the mastoid area, to check for any fluctuation, any tenderness, to check the overlying skin, is it red or not, okay? To look for signs of mastoiditis. This is really important. Mouth and throat examination. I always say good luck convincing kids to open their mouth. Sometimes, unfortunately, we should force them to do so because they have no other option. Examining the mouth should include first having a general look about the mouth hygiene, the teeth. Is there significant dental caries and poor oral hygiene? We know that poor oral hygiene can be linked to so many serious conditions like who knows what?
Infections.
Like? Yeah, local thrush, yes, what else? Endocarditis. Yes, endocarditis. So one of the risk factors for endocarditis is poor oral hygiene. So this is very important to comment on. The color of the lips, jaundice, cyanose, central cyanosis or not. Mucosa, the mucosa of the mouth. Any ulcers, the presence of any ulcers, any lesions, abnormal lesions that you might comment on. Comment on the gum, how healthy. Some tumors or cancers, they can present with bulging, enlarged, red, congested gums. So you need to comment on that. You need to look at the tongue, any fasciculations, that can be a sign of lower motor neuron lesions, tongue fasciculations. The size of the tongue, is it macroglossia or microglossia? The palate, soft and hard palate, the tonsils, the pharynx, to look for signs of infection, tonsillitis, pharyngitis, etc. One important thing also that sometimes gets dismissed is the presence of submucosal cleft palate. So usually cleft palate is very obvious to see. I'll show you some pictures later. So cleft palate is very obvious, you can't dismiss it. But sometimes we have what we call submucosal cleft palate. Submucosal cleft palate doesn't show when you examine the kid. Okay, so you need to palpate the palate to feel the clefting. This is number one. Or if you suspect it, you need to look for hints or signs on physical examination. Those kids with submucosal cleft palate might present with bifid uvula. Do you need that chunk of meat dangling from your posterior mouth? The uvula. Okay, تعرفوا يعني uvula? So بيجوا ببifid uvula. This could be a sign of submucosal cleft palate. Sometimes they also present with nasal speech. They have speech problems, swallowing problems, recurrent ear infections. These could be signs that there might be submucosal cleft palate that you need to look for. Okay. Neck examination. So neck rigidity, which could be a sign of meningeal irritation or meningitis. Any swelling of any sort, and there are many pathologies that can cause neck swelling, like related to thyroid and other like cystic hygroma and other lesions. Whipping of the neck. Whipping is the presence of like congenital skin folds running from both sides of the neck meeting the shoulder. We call it whipping, as you can see. Whipping of the neck. Can you see the folds? Connecting between the neck, alongside the neck, moving down to the shoulders. So whipping of the neck, which can be signs of some syndromes like Turner syndrome, for example. You have to examine the lymph nodes, the thyroid gland, and check the position of the trachea if it's well centralized. nose and sinus examination. This is to check for the shape of the nose, the septum, is it deviated or not? The color of the mucosa, is it pale? And this is what we see with mucosa. We see it sometimes with people with chronic allergic diseases or congested if they currently have rhinitis or inflammation of their mucosa. You have to check for the turbinates. Are they enlarged? Enlarged turbinates can also be a sign of chronic inflammatory process like in allergies, presence of foreign bodies, and this is a common problem in toddler age group when they start to crawl and walk and they want to explore everything around them. Sometimes any object, foreign object that they find, they can insert to their nostrils. So looking for foreign bodies. And if you suspect sinusitis, for example, you have to check for facial tenderness over the common sinuses like the maxillary sinuses, the frontal sinus, etc. Okay, chest examination. So generally, you learn in the introductory course, we comment on the shape of the chest. If there's any deformities like pectus excavatum, pectus carinatum. Looking also with inspection, like we need to check for what we call the rosary rickets, which are signs of rickets like small bony prominences and the costochondral cartilage areas, which is a sign of rickets. You have to comment on the breathing pattern. We know that in kids, breathing is mainly, specifically below the age of 2, it's mainly abdominal and diaphragmatic, right? So we need to comment on that. Any signs of respiratory distress, nasal flaring, supraclavicular, intercostal, subcostal retractions, you need to comment on all of those just by inspection. The use of accessory muscles, you need to also comment on that. Signs, as I said, of chronic allergic disease like what we call them allergic shiners and salute signs or salute lines. So allergic shiners, people with chronic allergic diseases, they might rub below their eyes all the time. This will cause like changes in the suborbital area. They will have the lower eyelid, below the lower eyelid, they will have like wrinkles, puffiness of the area, we call it allergic shiners, and salute lines because they keep rubbing their nose like this, so they will have a horizontal groove and line on the tip of their nose. So this can be signs of chronic allergies. And Harrison sulcus. What is Harrison sulcus? It's a groove like that we observe at the level of the diaphragm insertion, which is around rib number 6. And this groove appears when the patient has chronic obstructive diseases like in asthma. This is how Harrison sulcus looks like. So at the site of the diaphragmatic insertion, can you see the groove? So we see this in chronic obstructive diseases. Cardiovascular system also start with inspection. You know that. We will learn this in the introductory course. You check for cyanosis, pallor, clubbings, xanthomatous, Janeway lesion and Osler nodes, which is a sign of endocarditis, scars, deformities, individual pulsation. Okay, this is by inspection. By palpation, we comment whether there is heave, parasternal heave, and thrill, which is a palpable murmur. And we palpate for the apex beat. Below the age of 7, the apex is located on the 4th intercostal space. Above the age of 7, it's on the 5th intercostal space, of course, mid-clavicular line. And you have to measure the pulses as part of your cardiovascular examination. Below the age of 3 years, you're only required to examine the brachial pulse. Below the age of 3, you have to check for other pulses like the femoral, the radial, etc. You have to auscultate on the major, areas that we learn in the introductory course, the pulmonary, aortic, tricuspid, etc. And you have to do the special maneuvers if you suspect there's any murmur to potentiate the murmur and to observe any changes according to the position and so on. By the end of the auscultation, I expect you to say normal S1, S2, for example, no splitting, no murmurs, no adding sound, no rub like pericardial rub what we hear in pericarditis. Abdominal examination. Again, this can be challenging. Kids who are less than 3 years of age, you can get them to sit on their mom's lap and examine the abdomen while they're sitting, that's fine. You have to inspect, start with abdominal contour, is it distended, scaphoid. You have to comment on any visible palpation, any visible dilated veins, the location of the umbilicus, is it inverted, everted, central, etc. Percussion and auscultation. So one question, why do we, as part of the cardiovascular examination here, it says percussion. What do we percuss for in the cardiovascular exam? What do we percuss for in the cardiovascular exam? Why percussion? Excellent, liver. So the liver size, the hepatomegaly can be a sign of cardiac failures, right? So sometimes some examiners they might ask you about percussing the liver as part of the cardiovascular exam. You might mention it to the examiner for the sake of completion. They might ask you to skip. But percussion is a part of the cardiovascular examination as well. Okay. Musculoskeletal exam. So what do we examine with the musculoskeletal exam? So you look at the lower limbs, the upper limbs. If you enter the room and you observe the kid walking, you have to comment on the posture and the gait of the kid. If the baby is laying down, you have to check for symmetrical length of both upper and lower limbs, symmetrical size. You have to comment whether there's one side is like hemihypertrophy. Sometimes there's a condition called hemihypertrophy, whereas one half of the body is hypertrophied and the other half is normal. You have to comment on any anomalies that you observe. In young age group, part of the MSS exam should be examining for DDH or dislocation, congenital dislocation of the hip bone by doing the Barlow and ortolani test. Okay, so the Barlow test, the kid should be lying down, supine position. You do hip flexion at 90 degrees, and then you exert pressure on both knees, anterior pressure, okay, while adducting them. So adduction and anterior pressure, you push them posteriorly from anterior, as you can see in the arrow. So adduction and pushing the knees posteriorly, and you'll be able to hear a click. A click means, a palpable click, is that you dislocated the head of the femur from the acetabulum, which could be a sign of DDH, okay? To confirm that, if there's DDH, okay, if the hip joint is unstable, you should also be able to relocate a displaced hip, so to get it back to its normal position by what we call the ortolani technique. With the ortolani technique, you do, again, the kid should be lying down on their back, and you do abduction of the hip joint, so abduction, and then what you need to do is to push the femur trochanter outward, as with the arrow, so outward movement of the femur trochanter outward with abduction, and this is to reduce a dislocated hip. Again, you will feel a palpable clunk or click, and this confirms the presence of a dislocated hip or DDH. Okay, don't forget to examine the back, comment on any lesions, any obvious deformities like kyphosis, scoliosis, etc., any masses, tenderness, limitation of movement or motion, the presence of tuft of hair, okay, or sacral dimples, okay, which could be a sign of myelomeningocele and other spinal anomalies. Okay, so don't forget to examine the lower back area as well. Again, examine the genitalia. Appreciate the differences between the male and male genitalia. For the males, you have to check that both testicles have descended. You have to look for hydrocele, hypospadias, or ventral location of the urethral opening. If there's ambiguous genitalia, and if there's Tanner stage or puberty, signs of puberty, like commenting on the pubic hair if present or early on. The same for females. Look for any discoloration, enlarged clitoris, which could be a sign of ambiguous genitalia. Fused labia minora, when both labias are fused, this could be a sign of androgenization or excess androgen secretion. And again, comment on the distribution of the pubic hair and the Tanner stage of pubic hair. Okay, don't forget the anus as part of your physical examination. And just born babies, we have to comment on the anus if it's perforated or imperforated, the presence of fissures, skin tags, fistulas, hemorrhoids, etc. And this depends on the context of your history. Urological examination, of course, you observe first the mental status, level of consciousness, Glasgow Coma scale. Then you have to perform cranial nerve examination, specific cerebellar function exam, motor and sensory examination, primitive reflexes, and deep tendon reflexes. We know that primitive reflexes are involuntary motor movements the babies are born with. They originate from the brain stem. So with time, these primitive reflexes should be replaced by voluntary movements, because the brain stem, with time, with development, won't be controlling the movement. So the control would be shifting from the brain stem to the hemispheres or the cerebrum. Examining the meningeal signs. Okay, so for the meningeal signs, we have, as we learned, tenderness and neck rigidity as part of meningitis, as sign of meningitis. You also have to do the Carnex and Brudzinski signs. So with the Carnex, lying still, supine position, hip flexion, try to extend the knee. If there is positive meningeal sign, the kid will be resisting the knee extension. Okay. This is a positive Carnex sign. They might as well flex the other knee as a response to pain or irritation. Brudzinski sign, if you flex their neck, they will involuntarily flex their knees as well due to meningeal irritation. Okay, now this is the general examination of kids. Now we will move to some newborn specifications, so some specific signs that you need to look at in newborn examination. You're unfortunate that you won't be able to get into nursery and NICU to examine newborns, but there will be like examination on dolls, so just to get your head around the basics of a newborn examination. Okay, the first physical exam we perform on neonates or just born babies is measuring or documenting the APGAR score. The APGAR score is a very important quick clinical assessment of the well-being of the baby. It's a group of signs that we look at and give scores to at minute 1 after birth and minute 5 after birth. Usually the score is between 0 and 10. Healthy newborns who are very well usually score between 8 and 10. Distressed baby usually score below 6. Okay, so the score at 1 minute, it reflects the perinatal or delivery conditions. If the baby was distressed, for example, during an obstructed delivery, if they used, for example, morphine for the mom, this will cause, as you know, depression, respiratory depression, and decreased muscle tone in the baby, and this will be reflected on the APGAR score on the first minute. Minute number 5 reflects more the outcome or the trajectory of the outcome, how it's going to go. So if the baby is distressed at minute number 1, but with resuscitation, he's fine at minute number 5. So this reflects good outcome, and the baby should be able to go to nursery, normal nursery, and then discharge home like on time. However, if Apgar score on number 1 is decreased, and it's still decreased on minute number 5, this kid we can't take them to nursery, to regular nursery. They need to be transferred to special baby unit or NICU unit to be evaluated and managed accordingly. So Apgar score, the word Apgar stands for A, the activity of the baby at 1 and 5 minutes. Activity indicates the muscle tone of the baby. Okay, so if there's no muscle tone, the baby is floppy, not moving. This is a 0 score of the activity. If the baby has got flexed limbs, this is 1. And if the baby is actively moving their upper and lower limbs, okay, this is 2. So this is a full mark. P reflects the pulse. If the pulse is absent, this is 0. If it's there but less than 100, this is 1. If it's more than 100, this is 2. G stands for grimace, or what we call reflex to irritability. So we irritate the baby. So either we rub over their sternum, okay? Sometimes we insert an NG tube in their nose for 2 reasons. Reason number 1, to check how they react to that as a reflex irritability, and to check for the patency of their nostrils, okay? So if the baby does not respond at all to irritation and remains floppy, this is 0. If the baby shows minimal response, this is 1. If the baby starts to promptly respond, crying, shouting, this is 2. And this is what you'd expect from a healthy baby. The other A stands for the appearance, which is mainly the skin color and skin appearance. So if the baby is totally cyanosed, upper and lower limbs are cyanosed, this is 0. If the baby has what we call acrocyanosis. So acrocyanosis, the center of the baby is pink, but the extremities are blue, and this is very common in newborn babies, because when you cut the umbilical cord, the circulation will shift. So the fetal circulation will stop, and when the baby takes the first breath, they have to start or initiate their own circulation. So this takes time to be perfected and to be completed. So they might initially have acrocyanosis, so this is normal. So acrocyanosis, we give them 1 point, and if they are totally pink, we give them 2. R, this is for the respiratory effort. So if the baby is not showing any signs of active respiration, the baby is not taking their own breath without help, this is 0. If the baby is breathing but slowly and irregularly, this is 1. And if the baby is vigorously crying, vigorous cry indicates good respiratory effort and good tidal volume, so this is 2. Again, vital signs: temperature, heart rate, respiratory rate, blood pressure. In newborns, we might check capillary refill time, and of course autosat if needed. In neonates, when measuring the temperature, we avoid the rectal mode. Some babies are born with imperforated anus. So if they have imperforated anus and you measure the temperature rectally, you might perforate the membrane, and this might complicate things. So imperforated anus, they need specific surgical correction, and we don't want to mess around the area. So don't do rectal temperature on newborns. Heart rate, it should be auscultated for 1 whole minute, okay? So you don't do 15 seconds and multiply by 4. In newborn babies, you should do 1 whole minute. Anything above 170 is abnormal, and you have to evaluate the baby and make sure this is an actual reading or related to the baby being crying, irritable, etc. The respiratory rate, again, count for 1 whole minute, okay, due to the periodic breathing pattern that newborns have. So they will go into depths of bradypnea, and then maybe apnea, and then tachypnea, okay? So because of this periodic breathing, you can't just take 15 seconds and judge the respiratory rate. You have to do it for 1 whole minute. Blood pressure is seldom indicated in babies. There are specific indications to do blood pressure, like if you examine a kid with cyanosis, a pathological murmur, for example, you will need to examine them to measure their blood pressure, what we call it 4 limb blood pressure, to examine on upper limbs and lower limbs and see any differences between both. Like for example, if you examine a baby, a newborn, and you noticed wide spaced nipples and whipping of the neck, which is a sign of Turner syndrome, you need to examine the blood pressure on the upper extremities and the lower extremities and compare, because Turner syndrome, one of the anomalies that they come with is coarctation of aorta, so they will have discrepancy between the blood pressure on the upper limbs and the lower limbs. Capillary refill time should be less than 3. Sometimes early on they might have somehow elongated or delayed capillary refill up to 4 seconds, specifically if they have cold extremities after birth. Again, a very major part of your physical exam should be measuring the growth parameters and plot them on the growth chart specific for the gender and age. The weight, you have to tell me whether the baby has got a normal body weight at birth or no. So anything below 2.5 is considered low birth weight. Anything above 4 kilograms, this is high birth weight or macrosomia. We call it a macrosomic baby. We know that most kids, they lose up to 10% of their birth weight during the first days of life, because this weight is mainly fluid. And then they should go back to their birth weight by day 7 to day 10. In the first month of life, they should gain about 15 to 20 grams per day. Crown to heel length, so measuring the length of the baby. Again, last auscultation, they failed to do proper measurement of the length. They were measuring from here to the toes of the baby. This is wrong, so it's called crown heel. So from the crown, the highest point of their head, to their heels, just the heels, not the toes, okay? And this, هاي هون. لا, you have to extend. هلا sometimes تخيل إنه البيبي عامل dorsiflexion, فالتوز بيكونوا أبعد من الهيلز. يعني هاي الهيل وهاي التو. فأنت ما بتقيس للتو, بتقيس للهيل. Okay, so this is you straighten them. You straighten the foot عشان يكونوا toes will heel at the same point. So crown to heel. So your reference is the heel, not the toes. And this is the same for head circumference. Many of them failed to measure the head circumference correctly. So when measuring the head circumference, we start from the most protuberant area, bony area on the frontal bone, on the frontal area, going to the most prominent occipital area. Okay? This is how we measure the head circumference. So many of them, they measured it from here up to here. So the measurement would be much less than it should be. Okay, so you choose the most prominent frontal area to the most prominent occipital area. This is a normal posture of a baby who's just born. Notice the color of their skin, pink. Notice the posture of their limbs, both upper and lower limbs are flexed. Usually when they're born, their skin is bright red or pink. Sometimes they are plethoric or very congested, yani severely congested or very red. Plethoric skin color, we see it in babies born with, for example, polycythemia or due to excessive heating. Sometimes when we do resuscitate the baby, there should be a heater above their head. And there should be a specific distance between the heater and the baby. If the heater is very close to the baby and the baby is overheated, babies will look plethoric or very red. Again, comment on any edema of the eyes, face, scrotum or labia, any cyanosis. Okay, so this is baby who's just born. This is the normal skin tone and color. This is what we call acrocyanosis, which is the bluish discoloration of the extremities, while, as you can see, the upper part of the body is very pink, or the central part is very pink. As I said, acrocyanosis right after delivery is normal. You need to comment on the presence of what we call vernix caseosa. Vernix caseosa is that whitish, waxy, greasy material the babies are born with. So this forms during their fetal life, and it's very important during to lubricate their skin and to maintain their normal body temperature. also to prevent, the irritation from the amniotic fluid. When they're born, there was a debate whether to directly give the baby a bath or delay the bath. So most studies now recommend that no bath should be given to the baby at least in the first 24 hours of life. Some studies advocate delaying giving the baby any bath before 48 hours, because nowadays they recognize how important this material is to maintain a normal flora and microbiome of the baby, to maintain a normal skin pH, which later on will prevent or protect the baby from having so many skin conditions like eczema and even food allergies. So this is very interesting. So if someone is born for some of your relative, advise them not to give them a bath in the first 48 hours of life. Mongolian spots. Mongolian spots are like bluish discoloration related to the migration of melanocytes to the epidermis. Okay, they look like this. Okay, and they can appear on many sides: the back, the lower back, the buttock area. They can also appear on the upper trunk, chest. Sometimes they appear on the upper extremities. Okay, this is a benign condition, and usually Mongolian spots do disappear during the preschool area. So they take time and they gradually fade away. Back in time, there was a myth, because they are called Mongolian spots in our community. They said, oh, they might be related to some mental disability, like from the name Mongolian, but it has no correlation, no link to any underlying pathology or mental disability. Discoloration early on in kids is very common, as you can see in this photo, which is like peeling of skin over bony prominences. As you can see, this is very common, and it lasts usually for the first 2 to 4 weeks of life. You don't need to do anything, only good moisturization of the baby's skin. Look for any physiological jaundice like this. We will have to go through physiological and pathological jaundice in details in one of our next lectures. Just a quick hint: physiological jaundice never appears on day 1 of life. Okay, any jaundice in the first hours and first day of life is always pathological. Okay, so look for physiological jaundice. Look for what we call melia. This is melia. Let me show you a picture. Okay, like whitish spots that mainly appear periorally on the nose, forehead. This is because when they're first newborn, these sebaceous glands, they can't drain their secretions properly, so sebaceous secretions accumulate and give this appearance of melia. They should disappear with time. It's contraindicated to squeeze them or trying to evacuate them, so they disappear on their own. Some of the findings that you might see, what we call is salmon patch or stork beak, mainly on the forehead of the baby. Some babies do have it on the occipital area, and this is a collection of capillary blood vessels near the skin. Again, you need to examine the head, the anterior and the posterior fontanelle. So the anterior fontanelle, it's diamond in shape, the diameter of it, so it is 2 to 3 centimeters in width and 3 to 4 in length. It connects the both parietal bones and the frontal bone. Usually it stays open until the age of 18 months. So if it's open, you need to examine it, you need to comment on the size, as I said, soft, tense, etc. Delayed closure of the anterior fontanelle. So if you face a kid with delayed closure, so a kid who is 2 to 3 years old and has got still an open anterior fontanelle, this can be a pathological sign of many diseases like thyroid disease or Ricketts disease or severe vitamin D deficiency. The posterior fontanelle is a very small triangular shape that connects the parietal with the occipital. The size is very small, it's about 0.5 centimeters to 0.7 centimeters, and usually it closes around the age of 2 months or 8 weeks. When examining a kid, as I said, head examination, you need to comment on any swelling or lesions. Some of the lesions or swellings that you might face is what we call caput saxedena. So caput saxedena is a collection of fluids or effusion that overlies the periosteum. Okay, This happens because when the baby is born, specifically we see this in babies who are vaginally born, they will the pressure of delivery of the vaginal tract, they will have, this will exert pressure on their skull, and this will lead to the accumulation or effusion of fluid to the area overlying the periosteum. Okay, and this area, which is usually well defined, it has no defined margins, and it crosses the line because because it overlies the periosteum, so it's not contained by a bone. Okay, so it can move freely along the suture lines. Okay, and this is to differentiate caput from cephalohematoma that we're going to review later. Usually it doesn't cause any complications. Okay, usually the fluid will get resorbed on its own, and nothing needs to be done, only observation. This is how it looks like. It can be really big, caput saxedinum. Okay, with overlying areas of redness due to the pressure exerted on the skull during delivery. So it's very pressable, as you can see, because it's soft, it's fluidy. Okay. On the contrary, cephalohematoma are subperiosteal, so they are contained by the periosteum. So subperiosteal collection of blood. This is due to rupture of small capillary or blood vessels during delivery due to the pressure exerted on the skull. Because it's subperiosteal, it's limited, so it cannot cross the suture lines as in caput saxedinum. So sometimes on physical examinations, sometimes it's hard to differentiate between caput and cephalohematoma. So you have to look whether it's soft, very soft, or somehow less soft or hardening, or if it's crossing the suture lines or not, to differentiate between caput and cephalohematoma. This is how it looks like. So as you can see, because it's subperiosteal, it couldn't cross the suture lines. Can you see? So this is here and this is here, and they're not crossing the suture line. So sometimes this, if it's very big, you might be sometimes concerned. If it's big, it can cause pressure on the tissue below it, causing necrosis, tissue necrosis. If it's also very big and there's a significant amount of blood collection, this blood will hemolyze and the baby will become jaundice. So it might be one of the reasons of pathological jaundice on the first day of life. So you need to closely observe babies. Babies with large cephalomatomas, we keep them under observation. We don't discharge them home immediately. Part of your neonatal examination, to examine the eyes, to look for, usually you'll be able to see, like, it's normal to see edematous or swollen puffy eyelids, as I said, due to the pressure exerted during delivery. Usually they are born with the iris would be gray in color, and it takes up to 6 to 8 months for the final color to finally be specified. Usually pupils should be reactive equally to lights on both sides. You should be able to elicit the positive red reflex to light. Usually when they're born, babies, they don't have lacrimal ducts, so there's absence tearing. If you try to touch their eyes, they will have blinking reflex as part of their primitive reflexes. Babies born who are just born, they don't have the rudimentary fixation, so they cannot follow objects and they can't fixate their vision or gaze to a specific object. So this is how a normal eye color of a just born baby. This is a normal bilateral reed reflex. This is how it should look like, equal and symmetrical. This is opacification or cloudiness of the cornea, which is called cataract. Can be a sign of congenital infections like congenital torch infections. This is normal eyelid edema of a just born baby. This is subconjunctival hemorrhage, which is commonly seen in babies who are born by vaginal delivery due to the pressure exerted during delivery. Again, you need to examine the ears, as we just mentioned before. This is a normally looking ears. You have to feel them, palpate them, check the cartilaginous parts of the ear. Nasal exam, nasal potency, as I said, when they're born, when we are evaluating the APGAR score, we insert a small NG tube, nasogastric tube, a very small one, through the nostrils to both check for the baby's response to stimulation and to check for nasal patency. It's normal for babies who are just born to have thin whitish mucus discharge through their nose. This is the normal nose of a newborn baby. Can you see? This is Melia that we just mentioned. This is dislocated congenital nasal septum. Again, comment on the neck. Babies who are just born, they normally have short neck with very thick skin folds. So this is normal observation in newborn babies. So this is how their necks look like. Short with excessive foldings. Mouth examination. It's very important to examine the mouth of the babies to look for cleft lip, cleft palate. What you can see here are what we call Epstein pearls. This is a normal finding that we see over the hard palate of the babies, okay? And this should disappear on its own with time. We call them Epstein pearls. This is a normal finding. On the contrary, this is how a cleft palate looks like. Okay, so can you see the NG tube passing from the nose? And it's here. This is the NG tube, okay, with milk inside. So this is a cleft palate. This is a cleft lip. Okay, so usually the abdominal shape of a newborn baby is cylindrical. This is the umbilical stump, or what's left of the umbilical stump. Drying with time, it should fall off in the first 4 weeks. We can give it up to 8 weeks to fall off, usually. This is how a baby umbilical stump looks like just after delivery. So this is the clamp. So we clamp the umbilical cord and we cut above it, okay, to separate the baby from the mom's placenta. So usually we look inside here, and you should be able to see 2 arteries and 1 vein, 2 umbilical arteries and 1 umbilical vein, okay? This is a meconium stained umbilical cord. So a baby born with meconium, so passage of meconium up before delivery will lead to amniotic stained, meconium stained amniotic fluids, and the baby's skin, nails, nail beds, and the umbilical cord stump can also be stained with meconium. And that's it. Thank you very much.